Okay, so we're recording now. So welcome all. Let me start with our acknowledgements and disclaimer. So the EIC is supported by the Health Resources and Services Administration, HRSA, of the U.S. Department of Health and Human Services as part of the Emergency Medical Services for Children Innovation and Improvement Center cooperative agreement totaling $1.5 million with 0% finance from non-governmental sources. The content presented here and throughout this community of practice is that of the authors and does not necessarily represent the official views of nor an endorsement by ASPR, HRSA, HHS, or the U.S. government. So a quick agenda for today. We have three of our wonderful EMSC program managers that are going to talk a little bit about each of their programs and some great advances that they've all have made. And then I will start with just sort of a background of the community of practice, kind of where we're at now as far as recognition programs, and then I'll let Margot, Evelyn, and Heidi take it away with their presentations. So just briefly, to review, the goal of this community practice is really to work towards EMSC Performance Measure 4, and that is by 2022, 25% of hospitals are recognized as part of a statewide, territorial, or regional standardization program that are able to stabilize and or manage pediatric medical emergencies, and sort of why we're all here. But why is this important and why is it a performance measure? And there's quite a bit of data to show that the establishment of a pediatric medical recognition program actually leads to a significant improvement in the weighted pediatric readiness score. So you can see here from this graph that states, if they're located in a state without a recognition program, their weighted pediatric readiness score is significantly lower than hospitals located in a state with a recognition program. And we know that, and you'll see here once again that pediatric verified emergency departments have a significantly higher weighted pediatric readiness score compared to non-verified EDs. And that actually translates to decreased pediatric mortality rates. This is a paper that came out last year by Stephanie Ames showing that if increased weighted pediatric score was associated with decreased pediatric mortality rates. And that is actually independent of a trauma center verification status. So the results of this paper by Kate Remick had shown that you can see here, the trauma designation is not predictive of greater pediatric readiness. And so to address this performance measure, we started with the Pediatric Facility Recognition Collaborative, and that ran through from April 2016 through December 2017. And then we had the mission statement that all children deserve timely access to emergency departments that are ready to provide an immediate and appropriate care based on national guidelines for the care of children in emergency departments. And so our aim for that collaborative was by December 1st, 2017 to increase by 50% the number of states that have developed a recognition program. And that was successful, and you can, if you access the FRC white paper on our webpage, which is through this link, you can read about the establishment of the goals and the achievements of the facility recognition program. However, so in April of 2019, we transitioned the FRC to the Pediatric Medical Recognition Program Community of Practice, which is what this is. And really our goal is to offer quarterly calls to kind of continue support of ongoing activities towards establishing recognition programs. And so that includes sharing of best practices, troubleshooting challenges, and more. And so you can access all of our previous webinars here under this link. I think that's kind of all I had for the background. Oh no, let me give kind of an update on where we are now. So there's a total of 15 states. This is based on last year's data. Total of 15 states with pediatric facility recognition programs. You can see them here. The recognition criteria is based on the 2018 Pediatric Readiness in the Emergency Department Guidelines. Majority of these programs are voluntary. The host institution varies. But you can see here, of all of the recognition programs in each of our states, there is a wide range of the stages of development. And so we have 15 here at level 5, and I'll go through the different stages here on the next slide. but quite a few, 28 here, who are at stage 0 or stage 1. And what that means is stage 0 is no progress has been made towards developing a program, so you're just getting started. Stage 1 is sort of established an advisory committee, and members are beginning to work on this issue. And so we have the vast majority of our states in that, those two stages. Number 2 is the criteria has been developed. 3, there's an implementation process or a plan, so you know how you're going to do a recognition program, but haven't quite piloted it, which is stage 4. And then lastly, stage 5 is that at least one facility has been formally recognized. Are there any questions about sort of how we view the stages of development towards a pediatric recognition program?
Yes, hi, this is Fatma with Texas. I actually just saw Dr. Remick's message, and I just wanted to provide the same update that we just started our recognition program as well, and do have one hospital formally recognized so far. So very exciting stage for us.
Meredith, this is Mark. Can you just comment on formally recognized? Because I think based on my experience during the participation of the collaborative, you know, the formality of the program varies across states, and what do we mean by formally recognized? I believe that's self-report as someone has participated in whatever program you have created, be it a more grassroots program or a mandated Department of Health program. I just wanted to make sure that that was correct.
I can respond to that, Mark. This is Kate Remick. Yeah, the idea is that to whatever extent the state has developed the program. So in some states, it might be implemented through the health department, and others it might be really implemented or hosted through the state EMSC program, and others there's some combination thereof. But to whatever extent that program has been developed and finalized, it's the recognition process that has been set. So every state may have a slightly different method for recognition, especially when we're talking about states with large geographic spread like Alaska or California, Texas, and others, where some of that recognition may occur through a formal submitted application and virtual visits. In other situations, it may be on-site visits and meeting with the team. But it's through the host institution, whatever that might be in a state, that has developed the program and then has therefore been formally recognized. I'm not sure if that answers your question.
It does. I just wanted to verify for that group. I thought that was still the answer, but I think that particularly in New England, where even in our small region, there's a variation, whether it's this program or the PEC program. I think that our different states have taken different approaches. We're working towards a more unified approach for the hospital-based approach. And our programs have not necessarily gone through the Department of Health. And this was based on our needs assessment and discussion that doing this from a more, you know, what's the value to you, and a more carrot than a stick has been effective. I know in other states, the other approaches may be true. So I would describe our program as more of a, you know, we have formally recognized places, but it's been more of a grassroots and probably feels less formal to a number of our stakeholders just based on our needs assessment.
Yeah, I mean, every state absolutely is a little bit different. And part of the reason for the Facility Recognition Collaborative was to try to create some standardized criteria for readiness. You know, every state kind of chose a slightly different format, although based on, you know, the original joint policy statement and guidelines. And in some states, they have different tiers. Certainly having a PEC as a starting point towards that, but the great majority of programs are voluntary. And I think this is really the key point of, you know, developing, you know, steps 1 and 2 of onboarding stakeholders and making sure that they support and agree with the criteria in the program, because the more external stakeholder engagement there is and support for the program, the more it appears to be and actually is formalized in that way. anyone could come in and say, oh, I recognize, you as a pediatric ready facility, but unless there's stakeholder agreement that those criteria are meaningful, then it becomes, less useful. So that's kind of where these steps come into play, is really making sure that we bring in the stakeholders and that they believe this to be valuable. Hopefully that makes sense.
Yeah, this is Mo. Also, it'd be nice to have a longitudinal kind of view of how this kind of progresses, even from a place where somebody meets all the criteria to, mark everything on the checklist and be recognized. But then with the stakeholders, as you guys were describing, the turnover, some of these hospitals have a lot of turnover. And then when a new person comes and, they don't kind of understand what has already been agreed upon. So it'd be good to know how that actually progresses over time.
I think that's a great comment, Mo. And I think, our 3 program managers that are going to speak today could probably speak to that a little bit, as they've had their programs up and running a little bit. But I think that's a really good point. So with that, I guess unless there's any more questions or comments, I can turn it over to Margot to go ahead and talk about their program in Indiana.
Great, thank you. Hello, I am Margot Kneffelkamp. I'm the program manager for Indiana EMSC. I just celebrated my 4 years with IEMSC this past May as the program manager. Today I'll begin with team introductions, the overview of Indiana's Pediatric Medical Recognition Program process, key influencers and champions who served on the Facility Recognition Quality Improvement Collaborative Working Group, where we are today, and successes and lessons learned thus far. If you look at this slide here, Dr. Elizabeth Weinstein, she is the IEMSC program director and has been for the last 11 years. Dr. Weinstein is an emergency medicine physician in both adult and pediatrics, and she splits her time between the Eskenazi Emergency Department, which is the county hospital for Marion County, which serves all of Indianapolis, and also at the Children's Hospital located in Indianapolis, Riley Hospital for Children at IU Health. She's also Deputy Medical Director of Pediatrics for Indianapolis EMS, the largest EMS agency in the state of Indiana, and Chief of the Division of Pediatric Emergency Medicine at the IU School of Medicine. Dr. Greg Ferris co-chaired our Facility Recognition Quality Improvement Collaborative Working Group. Dr. Ferris is a pediatric emergency medicine physician at Riley Hospital for Children, and he's also a Deputy Medical Director of Pediatrics for Indianapolis EMS and the Indianapolis Fire Department, as well as Medical Director of Pediatrics for Riverview EMS, and also IU Health Lifeline, who operates a fleet of medical helicopters and mobile intensive units here in Indiana. And then we also have Dawn Michelle Sullivan-Wright, who is the Pediatric Chair for the state chapter of the Indiana Emergency Nurse Association. IEMSC is housed at the School of Medicine located at Indiana University. Indiana has 130 emergency departments with 92 counties. Of those 92 counties, 76 counties are wholly or partially rural, with 35 critical access hospitals and 19 small rural hospitals. I remember about 2 months into my role as the program manager, this was back in 2016 when I started with IEMSC, I received a phone call from Dr. Weinstein. And she was telling me that she had just gotten off the phone with Dr. Kate Remick, and she was excited to share with me that we should join the Facility Recognition Collaborative, and what do I think of it? I thought this would be a great venture, and with the program, and Indiana joined the Facility Recognition Collaborative 2 months behind everyone else. Next slide, please. Indiana's process. We established a working group who started to meet monthly. I have the breakdown of those on the next slide. We followed the national collaborative who went through the guidelines, and we developed the criteria for Indiana. We held a consensus conference in November of 2017 in partnership with the Indiana State Department of Health, and we asked attendees if this looked feasible for Indiana. Those in attendance were from healthcare systems and critical access hospitals throughout the state and included members of our working group. The agenda for the day was 4 hours that we blocked out. We sent the invitation and materials in advance to attendees, including the overview of pediatric readiness, other states who already have a facility recognition in place, and the process over the last 18 months and how we got there. During the meeting, we went through criteria domain by domain for the 2 tiers, and the highlight of the conference was there was more demand than we were ready to meet and would need to be mindful of efficiency and resources. Several attendees expressed interest during the meeting. Post this consensus meeting, the work group went back and revised the guidelines, and applications were made available in November of 2018 to begin highlighting hospitals for recognition. Next slide, please. Our committee consisted of the state chapter, Indiana Emergency Nurse Association Pediatric Chair, John Sullivan, Michelle Wright, that I mentioned previously, the Indiana State Department of Health, Trauma and Injury Prevention Division, as well as the Hospital Preparedness Division, member of the Indiana Rural Health Association, the Indiana Hospital Association, the Indiana chapter of AAP, and the Indiana chapter of ACEP, the Patient Safety Coalition chair for Indianapolis, and several pediatric emergency medicine physicians. We did not build a critical care tier at this time, but we'll look to add later. Indiana EMSC is the host institution with support of an FTE from the Hospital Preparedness Division at the Indiana State Department of Health. Next slide, please. The current state of Indiana's program is a 2-tier voluntary program. There is no cost to the institution applying. You can either apply to be pediatric ready, which is minimal preparedness to treat, stabilize, and transfer as needed, or pediatric advanced, which is pediatric ready with additional resources to care for children. Our goal would be Indiana would pilot 5 hospitals in year 1. An application packet consists of an EMSC cover letter, instructions for pediatric readiness application, the facility recognition criteria, the application, both pediatric ready and pediatric advanced, the site surveyor guidelines, and the pediatric equipment checklist. Next slide, please. The site verification process. The hospital will express interest and will receive the application. The hospital completes and submits the application back to Indiana EMSC. The application is reviewed by 2 team members. IEMSC provides written feedback, including gaps provided within 90 days of submission. If meets criteria, we will go ahead and schedule the site visit. The site visit is a half-day format and formal written feedback within 60 days, and then the hospital is given 90 days to address any deficiencies. Where are we today? To date, 17 Indiana emergency departments have requested the application packet. Of those 17 emergency departments, 3 have completed the application packet. On February 27th, 2020, the facility recognition site review team completed the in-person site survey at 2 hospitals, and both hospitals met criteria for the pediatric advanced level facility recognition. IEMSC is reviewing the 3rd application, and when timing is appropriate, we'll move forward with the in-person site survey visit. Next slide, please. Successes and lessons learned. The hospital must contact IEMSC for application. We decided to not have the application just yet on the Indiana EMSC website This has proven successful because I check in with the hospitals to determine who is close to submitting. Our team does a quarterly check-in internally, either on the phone or in person with the Department of Health, to share who is applying and where they are in the process so that we can anticipate demand. Online applications are now available. After the hospital reaches out to IEMSC, I send the application packet so the hospital can see what it all entails. Once the hospital is ready to move forward, I include this content in the email. I request for them to reach back out to IEMSC and request the online application. IEMSC has worked with the IU School of Medicine to develop the online application utilizing REDCap. We're able to review the applications electronically, have conversation back and forth with the applying institution, and serve as a tracking mechanism, as well as an easy location for grant reviewers to access the application and all documents online. The stakeholders conference venues, we utilize their platform. We rely heavily on our stakeholders and utilize their conferences or events as a venue to communicate the program. I often set up a booth with information, including things such as Indiana's state report, the upcoming NPRP assessment and checklist information, information about the facility recognition program, the EMS assessment. I also make sure that IEMSC is part of the agenda for the state chapter Emergency Nurse Association, EMS commission meetings, Indiana Trauma Care Committee, for example, which Dr. Weinstein is an appointed member of. I've presented during the Indiana Rural Health Association's Lunch and Learns, and also if I host a breakout session, then oftentimes my registration fee is waived. Next slide, please. Partnering with those who have done this before, look for templates. You do not have to recreate the wheel. I have utilized Illinois and New Mexico specifically in their resources. I spent time traveling to Illinois, where Evelyn graciously welcomed me to observe in-person site visits at 2 hospitals. Indiana has 3 hospitals that are verified by Illinois and will be grandfathered in at a later date. Utilize the current environment. I started to travel to the District Healthcare Coalition meetings. I mentioned the Pediatric Surge Annex and encourage hospitals to obtain an application packet and begin their gap analysis. Utilize EMSC as a resource to obtain facility recognition. I shared resource documents and toolkits by offering to attend their events. I include on tables or where I go a sign-up sheet for our monthly newsletter, as well as our quarterly PEC newsletter that they can sign up to receive. I also will draft content for various newsletters across the state, such as the First Responder that is published from the State EMS Division, the Trauma Times that is produced by the Indiana State Department of Health. I am working with the Indiana Emergency Nurse Association to have IEMSC located on their website and be able to connect emergency nurses to IEMSC. And then finally, keep the momentum going. Just before Indiana received their first COVID-19 case back at the 1st of March, I had the opportunity to present Indiana's facility recognition program and the NPRP assessment in February. It was the perfect arena to recharge and gain momentum for the program. In post-presentation, I have received more interest moving forward. Next slide. Thank you for your time today, and I'm happy to address questions.
Awesome job, Margot. Any questions about Indiana's program? Okay, I guess not. You can always use the chat box if you'd like to ask more questions about their program. But with that, we can move on to Evelyn with the Illinois EMSC.
Hi, can you hear me, Meredith?
Mm-hmm.
Good afternoon, everyone. I'm Evelyn Lyons, manager of the Illinois EMSC program with the Illinois Department of Public Health. In regards to our EMSC program, Kelly Jones is our EMS for Children coordinator, and she also works for the Illinois Department of Public Health. Our program is a partnership between our state health department and Ann and Robert H. Lurie Children's Hospital of Chicago. And Dr. Susan Fuchs is our principal investigator on our EMSC grants. And this partnership has really provided us with a wealth of clinical and academic resources through Lurie Children's Hospital that lends well to our program. And I was asked today to provide a presentation on our facility recognition program in Illinois and step through our timeline. So to provide an overview of our state demographics, Illinois is a fairly populous state with a correspondingly large pediatric population. The graphic that you see on this slide is our state divided into 11 colorized regions. And this structure is how oversight EMS and trauma services in our state. Our EMSC program went ahead and adopted the same structure with our facility recognition program, which you'll see as I go through the next few slides. Just to provide some geographic perspective, Region 11, which is located in the upper right side of that graphic, or the northeastern part of our state, Region 11 is actually the city of Chicago. And then the other regions that just immediately border on Chicago are primarily urban and suburban. And then all of the other larger size regions, primarily rural in nature with some urban pockets. So we've got a fairly diverse state with the need to be assuring that we're taking into consideration the various urban and rural perspectives. Then with respect to our hospital infrastructure, our state has over 200 hospitals. Some of those are specialty hospitals such as psychiatric, long-term care, or ventilator hospitals. And you can see that 185 of our hospitals have emergency departments and 111 participate in facility recognition. Next slide, please. Our EMSC program began in 1994, and our initial funding was through a type of grant that was provided for a few years at that time to assist states that had not yet established an EMSC program. And the grant itself was called a planning grant. It was for a small amount of funding, but I found it was really helpful because it basically supported a state to do some preliminary work to get your state program kickstarted. One of the grant requirements was that we needed to conduct a statewide needs assessment. Now understand, this was before NEDARC. It was at the time when paper surveys or help surveys were done. So we surveyed all the entities that are listed here, and it was really labor intensive, but it gave us a tremendous amount of information that clearly showed disparities and clearly outlined pediatric needs. And we found the data exceedingly helpful to share throughout the state, and it helped support and provide rationale as to why we needed to.
Do they take credit cards? And also,
in addition, the planning grant year allowed us to formally establish our EMSC program, get the word out as to who we were, and begin to build our infrastructure. So we convened our state EMSC advisory board that year, and then the board identified the need for committees and task force groups to look at specific areas of focus. We also defined our priorities, which included the need for enhancing developing pediatric protocols and standards, getting involved in injury prevention initiatives, accessing data to continue to support our efforts. And then last but not least, the board felt strongly that we needed a task force to specifically look at facility recognition. Obviously, we didn't know how this would evolve, where it would lead, but we just knew that we wanted to definitely explore this concept further. Next slide. And so with that, we convened a facility recognition task force later that year. We never thought at that time that 26 years later, this task force would evolve into a standing committee that continues to meet every other month. This slide outlines the representatives that we have on this group and who we brought together initially. So we found that it was really helpful to have representatives from the professional organizations that are listed here. And that's really critical because these are the organizations that you really need to have support your efforts. And the individuals who serve in this capacity also need to be people who will go back to their organization, share information, garner support, engage their organization in EMSC, and utilize their newsletters, their listservs, any other form of communication to get the word out. The other key partner is the hospital association. You definitely want to get them on board with your work. And then we also found that it was helpful to have representatives from our perinatal and trauma systems when we were initially building our program. These are systems that were already in place in our state. They were both very robust systems, and we found them to be exceedingly helpful in providing tips and strategies for navigating certain issues. For example, after a few years, as we were rolling through the facility recognition process, we began getting feedback from recognized hospitals that they didn't feel that they were getting very good feedback from hospitals that they transfer pediatric patients to. And then when we approached the pediatric tertiary care centers, they acknowledged that they felt challenged by HIPAA, and that's why the feedback wasn't as strong as it could be. And in talking with our perinatal partners, they identified that this falls under the auspices of quality improvement, and they said that they include language in their transfer agreements. So with that, we began writing up a requirement that all transfer agreements are one of our facility recognition requirements, but we included language with that transfer agreement requirement. And that is that they have to have verbiage regarding the sharing and communication of information on patients, as well as quality improvement information, if there's any learning opportunities that could be shared with the sending hospital. So it's still not a perfect system, but it's much better than it had been, and it's helped to build those relationships between the sending hospitals and the receiving hospitals. Also listed on this slide are the individuals. We wanted to ensure that we had individuals who currently serve in a clinical role or have a close connection to that role so that they could provide feedback at the table as to what's realistic and reasonable to expect from hospitals. You really don't want to move forward with requirements that once you try to roll them out, there's a lot of pushback. So you want to be sure that you have folks at the table who can help work with you and make sure that the language is written in a manner that's going to be found to be acceptable. Next slide.
So real quick, we had a question from Liz Kendrick on kind of what you included in your needs assessment. And, they're looking to do a similar thing with their hospitals in the COVID and post-COVID area, assuming most of them have different pediatric priorities now. Do you think you could speak to that real quick?
Sure. So I could actually send a copy of some of the questions that or send a copy of the surveys themselves. But we asked, for example, we asked for the percentage of staff that, and this was back in 1994, remember? So we asked for the percentage of staff that, nursing staff, physician staff, who've completed a PALS course, APLS course, and ENPC was actually just beginning at that time, but we included it as well. And then we also asked for their percentage of completion of the equivalent for the adult population, an ACLS course. And it was just pretty impressive, where we saw 90-some% completion by nurses and physicians for an ACLS course, and declined to in the 20s, like 29%. And then ENPC for nurses was only about 5 or 6% at that time because of it had only been a fairly new course. But the disparity was striking, and it was something that we were able to share with the hospitals. And the reason was because ACLS was a requirement not a pediatric course. And so that helped to justify the need to include it as a requirement as we moved along with the requirement. So we looked at all different aspects. We looked at education, quality improvement. We looked at policies, and also equipment and supplies. So I tried to look at all of those key areas that we focus on with our requirements. Does that help?
That was great. Thank you.
Next slide. And so we began the task force at the end of 1994, and just so people understand that it does take time, it took us until 1998 to develop many of the key components that are needed. So it was about a 3.5-year process. Remember, this was prior to PEDS Ready, so although there were resources, some of the resources for facility recognition were a bit limited. Our first charge was to develop the requirements for hospitals, and we used models from other states such as California and also national recommendations. We also, and just to go back a bit with these requirements, there was so much discussion at these meetings, and it was good, but we would sometimes feel like we had just taken a few good steps forward, and then we'd come to the next meeting and we'd find that we needed to backstep a bunch of steps because the hospital association had some issues with something that we wanted to do, or there were some other concerns. So we tried to be very patient, and we continued with just moving forward. But that's an expectation that I think most states will probably, it's something to just expect as you move forward with your process, that there may be some of those kinds of issues. But the main thing is to just have your goal in mind and continue moving forward towards it. So we also needed to develop an implementation process. We initially wanted to make it mandatory for all hospitals, but then the hospital association stated that they would not support it if it was mandatory. They were very supportive of facility recognition, but they just felt that it might cause undue hardship for some hospitals. So we needed to transition to a voluntary process, but with the goal to make it as inclusive as possible. And that's why it was really important to have them at the table. Without that, we may have moved forward and then not found that out until later when we were ready to begin implementation. It was also agreed upon that a tiered process would work best, so requirements could be scalable based on hospital resources. The 3 levels that are listed here include our SEDP level, EDAP, and PCCC, and we'll describe those a little bit further in another slide. And we started out with just focusing on the first 2 levels, the SEDP and the EDAP, which just focus on the emergency department capabilities. Another component that needed to be addressed is all the documents and process components that you don't necessarily think about at first. For example, it's not just enough to develop the requirements. When you're ready to roll it out, there's a need to have a hospital application and a process that goes along with it. In our case, it was, do we open this up to all hospitals in the state, or we opted to conduct it on a region by region basis, and we went into each region, got buy-in from the region, and then rolled it out regionally. There's a need to decide on the survey team composition. What kind of training and expectations do you have for your survey team members? There needs to be checklists that you use during the survey, as well as template letters that you send out to the hospitals before their survey. And then what kind of letters do you send out after the survey to provide a summary of the survey? And then if there's required documentation that you still need them to submit, or we'll also list recommendations in the letter as well, things that they should consider doing but aren't really part of our requirements, but they would be helpful for them to work on. And then we also have to maintain, as the state health department, we have to maintain documents for a certain number of years as part of document retention. So that's something also as you move forward with facility recognition, another component to consider. And you may want to check with perinatal and trauma systems or your stroke and STEMI programs to see how they handle that if it's taken care of within your state health department. And then another area was to define the responsible entity. In our state, we defined that it would be our state health department that would designate the hospitals. But there are some states that are using their state AAP or state ACIP chapters to do that as well. Next slide. And so by 1998, we felt that we were at a point where we were ready to roll this out, and we piloted it first. So we felt that we didn't want to just roll it out without really getting a sense if this would be workable and whether there might be some pieces that we hadn't thought of that we'd want to tweak a little bit more. And so we got 2 advocates within an urban region and a rural region, and they really promoted it within their region. I mean, we went in as well, but they were there. They were leadership individuals within the 2 regions that we selected, and they were able to stand at the front of the room and really encourage their hospitals to do this. And it gave us some really good feedback by piloting it. Also, particularly feedback in terms of how it flew in a urban and a rural region. So it gave us that perspective as well. And things went well. There was a lot of enthusiasm for it. And so by the next year, we began statewide implementation. And as you see our regional breakdown, we began doing it region by region. Each year, we would do 2 to 3 regions, and it took us 4 years to complete the process. By 2000, we had gotten the requirements adopted into state regulations. So even though it's a voluntary process, if a hospital goes through the designation or recognition process, they're then required to meet those requirements. By 2002, we had started working, we initially focused on the EDAP and the SEDP levels. And in the background, as we were rolling those levels out, we continued working on the Pediatric Critical Care or PCCC level. And that level goes beyond the doors of the emergency department. And California had a similar process in place. And so we really did want to get there at some point, because it's a way of just really encompassing the whole program and being able to have those partners who EDAPs and SEDPs transfer patients to and have them as part of that. They're also the facilities that can lend expertise with guidelines and clinical pathways and treatment modalities and just share information and education and resources. So we definitely wanted them in the process as well. And then we began our 4-year renewal process at that point. Now by 2005, there was disaster funding that was being funneled out to the states a few years prior to that. And there was areas of focus in every state. And so one of the things that came up during one of the discussions about better preparing the hospitals from a pre-hospital perspective was that there was a recommendation that EMS resource hospitals within our state, which are the lead hospitals that provide pre-hospital oversight, it was felt that all of them should be participants in this process. And the majority of them already were. And so we were able to get that through as a mandatory requirement for those hospitals. And I'll tell you, we always had the Hospital Association at the table. They were against a mandatory process at the beginning, but when we got to this point, they were very much on board with requiring it for these hospitals. They still were reluctant to expand that mandatory requirement statewide, but they were good with us extending it to these 63 hospitals. And so again, it was great that they've been on board with us all this time. And when they saw how successful things were moving, they were willing to agree to that particular area that we focused on. Next slide. So those were kind of the key early years. On an ongoing basis, we continue to focus on facility recognition. It's one of our core components within our program. As I mentioned earlier, our facility recognition task force eventually evolved into a standing committee. There continues to be ongoing work. We actually meet every other month, and there's always a full agenda and things to work on. We then began our renewal process, which flows every 4 years. And we've had some fluctuation with hospitals. We've pretty much always maintained around the same number, but have gone up and down a little bit from that 111 number. We've had some hospitals that have closed. We've had a few hospitals that have withdrawn from the process. We've also had some that have withdrawn and come back into it. We've had hospitals that haven't been recognized that newly come on board. We've even had a few newly built hospitals that have come on board as well. And so, you know, after we've completed the initial implementation, it was clear that we needed to have a renewal process because it was important to keep going back. As someone mentioned earlier, with the transition that goes on in hospitals, sometimes this can fall off of people's radar. And when you have an entire team in the emergency department move on, then there's no one there who may remember that they're in EDAP or what they're required to do. And so it is really important to come back every 4 years and ensure that they're still maintaining those requirements. And then we also use the facility recognition program or committee to identify resources that are needed. So we have some online educational modules that we've developed. We've also developed a number of quality improvement resources. And then we've been fortunate to get pediatric or to develop pediatric disaster resources through HPP grant funding that we've received. And this committee also looks at revisions or makes revisions to the state regulations that then are funneled up to our leadership and to our legal department to implement. So we've tried to stay current with any new requirements or recommendations through Peds Ready or other national organizations. And then we've just tried to continue to identify opportunities for improvement and ways to enhance the process. And one of those ways is that we've needed to make some adjustments, obviously, with COVID. And we had surveys that were scheduled in the spring that we needed to cancel. We've postponed them to August and early September, and we're going to hold those virtually. We've never done this before. We're flying by the seat of our pants, but we feel really good about the documents that we've developed and the process that we put in place. We've done training for the hospitals, we've done training for the surveyors, and we know we're going to learn more from this, but it's another component that now we'll have in our back pocket if we need to use it for the next couple of cycles of renewals. Next slide. These are this slide just outlines the 3 levels. The SEDP level is those hospitals that are considered smaller, typically critical access hospitals. And what we mainly want to ensure is that these hospitals have the capabilities to recognize a child that's in trouble, that they can initiate what's needed in terms of clinical management, and then arrange transfer to a higher level of care. And these hospitals typically are consistent with a standby or basic emergency department. They may not have 24-hour physician coverage in the ED. There may be a physician on call with a advanced practice provider providing 24/7 coverage. They typically don't have inpatient pediatric capabilities, but they do need to have transfer agreements in place. And then the EDAP level is usually consistent with those hospitals that provide more comprehensive ED care. They may have some pediatric inpatient services, but may not have specialized or critical care capabilities. And they also need to have transfer agreements in place. And then the PCCC level is those hospitals that provide pediatric intensive care, pediatric specialty services. They have to meet all of the EDAP requirements. And then in addition, there's a number of inpatient requirements related to their PICU and pediatric unit capabilities. And they're the hospitals that then the EDAPs and the SEDPs coordinate transfers with. And so they have to develop transfer agreements with those hospitals, and they also have to have a transport team or be affiliated with a transport system. Next slide. This slide gives a like an overview of our core requirements. So we have facility criteria, we have people criteria, so requirements for physicians, advanced practice personnel, nurses, policies and procedures, transfer and transport requirements, quality improvement. And quality improvement includes having a pediatric physician champion and a pediatric quality coordinator. And those individuals are kind of our key connection to the hospital. So we have email addresses and we communicate with them on a regular basis. And so they're the core person who, if we hear that they're gone, then likely things may tend to fall apart at that facility. And so we need to contact the hospital and make sure that they've got someone else moved into that role, and we'll provide them with a brief orientation and orient them to our website, and then hope that then they're able to continue on with things, or they can always come back and follow up with us if more assistance is needed. There's also equipment, supplies, and medication, and then there's a whole checklist that we have for pediatric disaster preparedness that they need to meet as well. Next slide. This slide just expands just a little bit more, just to give you a little bit of an idea in terms of some of the requirements. So we don't just say that there has to be pediatric education attained by the physicians, nurses, and advanced practice practitioners. We actually define the number of hours, because it's very nebulous if you just say they need to have education. So we actually will ask them to provide verification of attendance of those hours, either through course certificates or by other kinds of mechanisms that they can confirm that with. But the physicians are required to have 16 hours of pediatric CME every 2 years. Advanced practice are the same. Registered nurses are 8 hours every 2 years. And when we look at the overall requirements for licensure, physicians in our state need to maintain 150 hours every 3 years. So to ask them to just allocate 16 of those hours every 2 years to be pediatric specific is not really a lot, but at least it helps to assure that they are getting pediatric focused education. There's also specific policies, requirements. The requirement is listed there that I mentioned about including in their transfer agreements that they have to have communication and quality improvement sharing between receiving and referral hospitals. And then pediatric quality improvement, we have defined indicators or monitors that we want them to look at: all deaths, all interfacility transfers, all child abuse and neglect, and then critically ill and injured children in need of stabilization. All 4 of these are what we consider high-risk cases. They can certainly do other monitors above and beyond this, but those are the key ones that we want to see them doing. And then again, the pediatric physician champion and PEDS quality coordinator, who's usually a nurse, those correspond with the roles that are in PEDS Ready. And these are kind of the core advocates at the hospital that really help to assure that they continue to meet their requirements. And then we also require that pediatric quality coordinator participates in regional pediatric quality improvement meetings. Next slide. So those meetings are usually held quarterly. It follows that regional structure that I pointed out earlier on our state map. And each region comes together. One of the hospitals acts as a chair. They'll rotate the chair every couple of years, and they focus on a regional project. So they come to consensus on what they want to focus on, and they will work regionally. They'll also use that as an opportunity to share resources, share education. They really find it helpful in terms of being able to mentor each other, particularly if someone new comes into the role. And sometimes it's the chairperson from the regional committee is who will contact our office, letting us know that a hospital has lost their pediatric quality coordinator and needs some support from us. These are just some examples of some regional projects, and I just highlighted in red the last 2 there, pediatric sepsis and interfacility transfer, because those are 2 that a number of hospitals within a number of regions, are focusing on that currently. Next slide. And so where are we at today? As I mentioned earlier, we have 111 recognized hospitals. That there's a breakdown on the slide here as to how many in each category. Hospital utilization, about 79% of ED visits go to one of our recognized hospitals, and about 95% of pediatric admissions are to one of those recognized hospitals as well. In terms of pediatric readiness, and I know we're getting ready to do another pediatric readiness, so this is a few years old, but we had 97.8% participation. Our state median score was 83, with the national median being 69. And you can see how the higher level hospitals and the hospitals who participate in facility recognition scored higher than those non-recognized hospitals. So again, this was an eye-opener for the non-recognized hospitals to see how they compared with those recognized hospitals. Next slide. So just to go over the next few slides are going to just contain some key steps and strategies that we found helpful. Our EMSC program, as I mentioned earlier, is a partnership between public health and academic and clinical, and that's been a huge help to be able to have that access to the various resources that we can get from the academic center. We've also we've been super fortunate to have support by key organizations within our state that are listed there. And that initial needs assessment was really helpful in really giving us some good information and getting us kickstarted and on the road to where we're at now. The designation of a task force or a committee, that was really helpful. It provided us with that infrastructure and evolved into a committee that continues to meet today. And then being able to have access to a number of resources that were outside of our state and also within our state to help us move along with this process. Next slide. I think piloting the process in 2 regions also was helpful. As I mentioned, we identified a respected leader in each region that served as an advocate and really was helped to spur the hospitals on to do that. And then they've continued to maintain that over time. I think beginning small and not trying to do everything at once is important. So it looks like there's a lot that's been accomplished, but we've been doing this now for a couple of decades. So we started with just those first 2 levels, and we added the PCCC tier later. And we went into each region with informational sessions as we began the process, and we continue that today. So even as we do renewals, we have an educational session first, and we bring everybody to the table from all the hospitals, and we review the process with them and get anyone new who's come on board in the meantime up to speed on EMSC and what the facility recognition program is all about. It's also really important to get the requirements incorporated into your state regulatory process, because that's the teeth then. That's what really helps assure that the hospitals will stay compliant to those requirements. And then we made a big deal about it as each region went through recognition. We held an initial recognition ceremony in each region to honor the hospitals, and it was a big deal. I mean, they had done a lot to get there. And so both our state health department and our state hospital association had representatives at each of those ceremonies. We presented the hospitals with framed certificates that we still see in their emergency departments today. We did press releases, and we continue to list the recognized hospital names on our state health department and EMSC websites. And so now when we do renewal, the hospitals get a letter that recognizes their renewal, but it's really important to recognize their efforts in the beginning and all throughout, but especially that first time through, it was really important to do that. Next slide. I think I mentioned that we also secured other sources of funding. That's been helpful to us over the years to be able to branch out and build on some of our efforts. And then listening to the hospitals and trying to provide them with assistance. So if they voice concerns for educational support or the issue about the transfer or the transfer feedback, to be able to go then to the hospitals and set up a process that's going to be workable and it's going to provide them with some positive feedback. And then developing resources as needed. We've done a lot of disaster preparedness. We've gotten funding through the HPP grant that goes to Lurie Children's Hospital. And so we have a preparedness coordinator, Anna Sherry, who is responsible for that and does a wonderful job. And then we have access to our state data sources and data personnel that's been helpful as well. And again, just patience and perseverance. It will take time. Don't worry if it seems like the ball gets dropped at times, but you will get there. Just continue to keep that goal in mind. And I think the next slide really kind of exemplifies this. So even though we've accomplished quite a bit, there's still a lot more that we need to do. And I like this slide because it shows that even though people may see what you've done, they have no idea, and it never reflects what really occurs beneath the surface and all the work and effort that gets put into something that that gets developed, especially on a statewide or a system level. And so just keep going. I know all of you are going to be successful. I'm really excited by the enthusiasm that I see within the states and by the other EMSC coordinators. And if there's anything that we can help with over time, please feel free to reach out. And I'll conclude at this point. I probably talked way over my time, but I'm open for any questions if anyone has them.
It's a fantastic amount of work, Evelyn. I know there were a few questions in the chat box, but while I scroll through to find them, does anyone have some questions right now?
Yes, hi, this is Fatma. Great stuff, Evelyn. Thank you so much. You have been a great resource over the past few months for us in Texas. I've reached out so many times, and all of your documents have been amazing. Just to help us get started. My question for you, just from what I saw on the slides, I'm curious to learn a little bit more about how you collaborated with the other programs around your state, mainly your HPP program, because here in Texas, I'm just trying to get a better idea of how to not only engage our stakeholders and keep them interested and keep them focused on this goal, but I also want to better learn how to use other programs as well. So if you could maybe share a little bit more about that, would be great.
Sure. Well, what's been fortunate for us is that the office that I work in, the Office of Preparedness and Response at the State Health Department, the Division of EMS falls within that office. So that office also oversees the HPP and the FEP program. So, and those are the programs that bring in the funding from ASPR on the HPP side and CDC on the FEP side. So it was beneficial for us where I sit, because I was able to communicate the need for pediatric disaster preparedness to be a priority. And so because of that, they were able to allocate a portion of HPP funding early on, shortly after 9/11, and that was before it was HPP. It was actually funded through HRSA at that time. But we've always been able to get funding, and that funding goes to Lurie Children's Hospital as our partner, and they've been able to use that funding to support an individual who helps develop pediatric disaster resources. That person is also very involved in our facility recognition program, because when we go out and do site visits, she's a member of the survey team. So she will break off from the rest of the team, and she'll walk with the emergency management or disaster person for that hospital, and she'll look at their incident command and ask about the inclusion of pediatrics during their pediatric meetings. She'll go up to the pediatric units, and if they have pediatric patients, she'll ask about pediatric evacuation capabilities and where they keep their evacuation equipment. She'll look at their decon area and assess whether they've got warming measures and thermometers to make sure that the water temperature falls within a certain range. And then there's a slew of equipment that she'll look for from a pediatric perspective to see that they have it within their cache. But that's been really helpful to get that funding. And so I think it's probably more so because where we sit within our health department that that they've been willing to provide that funding because, you know, we can justify the need for it. When it's a different area, I think you're going to need to go to meetings and begin to develop a relationship with the HPP manager or coordinator within your state to be able to do that. In terms of other programs, our trauma system also falls within the division of EMS, our stroke and STEMI as well, and our perinatal is under Women and Children's Health, but we developed a good relationship with them, and we've tied in with them, especially with school health, because the school health program falls under their office, and it's also within the state health department. But we've tried to utilize our relationships or where we sit within the state health department to build on some of those relationships.
Awesome. Fatma, did you also want to ask your question about selecting regions to pilot in the initial 4 years?
Yes, I had asked the question earlier when she was going over the pilot. So, Evelyn, I'm just curious. You have 11 regions, we have 22, kind of a similar distribution of rural and urban. And I'm just also curious how you selected which regions you would pilot in every year. At this time, we're doing more of a hospital approach. If a hospital is interested, we'll work with you. But I'm very curious to learn about your regional approach too.
So the original 2 regions that we selected were, we had physicians who were on our task force that were really strong advocates for the program. And so they volunteered to be, and one was from an urban region and the other was from a rural. So we kind of selected it because they volunteered to be the first 2 regions. And so we utilized them to be the initial pilots. And then we just kind of sketched out a plan after that in terms of what would be workable in terms of structuring regions based geographically, because some of the regions we do together, for example, regions 4 and 5 are the southernmost regions in our state. So we always felt that if we did them, we would do them together, because it would assure that when we're traveling that distance, it requires overnight lodging, and we would do both regions at the same time. And so some of it had to do with geographics, and some of it had to do with what worked out in terms of structuring the process itself. And then we've just continued that process, how we initially set it up. So we just kind of went through, and for a 4-year time frame, we just assigned regions primarily based on geographics.
Okay, great, thanks.
There was also a question from T. Evelyn on if maybe you could share your orientation materials used to educate hospitals about your program, even during renewals.
Sure.
Awesome. Yeah, if you want to send it to me, I'll make sure it's available on the website and send it out to everyone.
Okay, I'll send you the slides that we used for the region that we just recently conducted a renewal process with.
Fantastic. Thank you.
You're welcome.
Any more questions for Evelyn before we move on to Heidi in California?
Meredith, if we have time, just one quick question about Evelyn. That was fantastic. This is Mark. My question related to the ongoing requirements that you alluded to with the state, and just briefly, if you can expand on it. So is that they're required to do that for that 4-year period? Are they required to do it forever? I like the idea of that blended voluntary regulatory, but I just was trying to understand how it worked.
Good question. Yes, the requirements, as long as they are recognized by the state during that 4-year time frame, they're required to meet those requirements. Now, we have had hospitals where they've needed to withdraw. For example, we had a hospital that changed from an acute care facility to a long-term care facility. And so obviously they needed to withdraw because they no longer were going to have an emergency department, and their entire structure was undergoing transition. So there's cases like that where obviously there's the need to be flexible and address the changes that they're going through. But typically the letter that recognizes them or that recognizes their renewal identifies that this renewal is intact until, and it has a date of 4 years, and they would be required then to continue to meet those requirements during that 4-year time frame. And we can actually go in at any time to do a reinspection if we feel that it's needed. And then we have had times where we've gone out and done a renewal survey where there's been a gap with personnel and we're feeling that they just haven't gotten it back together again. And we'll give them, you know, a period of time to put together a corrective plan of action. And then we'll come back in 6 months or 9 months and see how they're doing and reassess them. So we do have the ability to do that as the state health department. So that's why it's important if you can get the requirements into your state regulatory process, because then you've got the state agency that has the ability to do that.
I think that was a pretty good segue into Heidi's presentation on California EMS for children and how they worked into the regulations. So Heidi, do you want to take it away?
Good morning, everyone. I'm not sure how many of you are in the afternoon yet, but hello. And I'm Heidi Wilkening. I'm from California, the EMS for Children coordinator here. And I'm going to talk about our EMS for Children regulations that we set up that went into effect last year. And some of you have already seen this presentation, and thank goodness I don't have to do it face to face because I do not like that. So next slide, please. I want to go over some general terminology. California works in a 2-tiered legislation level. So EMSA is the Emergency Medical Services Authority. That's the state level. Our LEMSAs, the local EMS agencies, are the county or regional level. The agency is the governmental entity, which is the LEMSA, and the providers, what we call providers, are the EMT and paramedics, or boots on the ground people. Next slide, please. Basic California statistics, we have over 160,000 square miles of area and close to 40 million residents with a summer tourism population of approximately 46 million, but obviously that's not correct right now with COVID. Next slide, please. EMSA operates under the California Health and Human Services Department, and we are designated by statute to serve as the lead agency for all planning, implementation, and evaluation of the statewide EMS system. Next slide, please. Health and Safety Code establishes EMS in California as a 2-tiered system of governments, as I spoke about before. The LEMSAs under Health and Safety Code 1797.204, I'll let you read that. And each LEMSA has its own set of policies and procedures, and they're responsible for the operation of EMS consistent with statute and regulations implemented by EMSA at the the county or regional level. Next slide, please. This is a map of California that shows all of our LEMSs. As you can see, we have some multi-jurisdictional. We have 33 LEMSs in the state of California. Some are individuals, some are multi-jurisdictional. Next slide, please. As it says, generally, we do not have the ability to provide direction to agencies or hospitals on their operation absent statutory or regulatory change or compliances with issues without first contacting the LEMSAs. This is where we have issues with some of our surveys. We have to get approval from the LEMSA to be able to contact the boots on the ground or the hospital personnel in order to complete surveys or work with the LEMSA. The Office of Administrative Law is in charge of development of regulations. The framework and operating regulations are developed by a detailed process that must be followed exactly in order to gain the Office of Administrative Law approval on regulations package. And the OAL staff that is reviewing all these regulations are not medical people, and they don't really understand EMS or medicine. Next slide, please. So there's a long process to be able to get a set of regulations through the Office of Administrative Law. Obviously, the concept is drafted by the state. The drafted regulations must include an initial statement of reasons for every line item in the regulations. This explains the reasons why the agency is making the proposed regulations. It can get repetitive, so items are sometimes grouped together. We submit the regulatory package and the fiscal impacts statement, which must be done to show an impact to the state, stakeholders, or the public. And all documentation is submitted to the Office of Administrative Law for initial review. Upon Office of Administrative Law initial approval to move forward, the process clock is started, and we have 365 days to complete the process. There is a minimum of one formal comment period for stakeholders and public during the one-year clock. At the completion of the public comment period, EMSA reviews all comments submitted. Additional public comment periods must be provided if EMSA determines the modifications are needed. The initial public comment period must be a minimum of 45 days, and additional comment periods must be a minimum of 15 days. And yes, Mary Ann Gaucher-Hill, you are correct. Often multiple comment periods are necessary. Upon the completion of the comment periods, the final regulation package is submitted to OAL for approval, and they have to give their decision within 45 days. Disapproved regulations may be rewritten and resubmitted to Office of Administrative Law within 120 days of receipt of the notice, detailing the office's reasons for disapproval, and it must include a 45-day comment period. As complicated as this process might seem, in recent years it's become more stringent based on administration's desire to see less state-level regulation and more local control. And the new governor works very similar to that of his predecessor. EMSA has seen regulation packages take 4 to 5 years to fully develop and receive approval from OAL. I know that they started on these regulations well before I started here in October of 2015. Next slide, please. The EMSA TAC and system stakeholders had asked EMSA to work on a set of regulations, and as priority tasks were completed, EMSA committed to the development of EMSC regulations, which was with a multidisciplinary task force of stakeholders, including the TAC and EMSA. We developed the regulations, took about 5 years plus. Monthly meetings for the core group and subcommittees met as needed on point topics, and most meetings were full day in-person sessions and took place in both Northern and Southern California areas to accommodate travel. The time frame was long due to stakeholder debate over content with the regulation drafts. Next slide, please. The completed draft was sent to and reviewed by agency, the Health and Human Services Agency for California and the Department of Finance, and it took a considerable amount of time into many months. And upon completion of the required pre-OAL evaluations, the draft regulations were entered into the formal rulemaking in March of 2018, and the clock ended on March of 2019. EMSA had 120 days to respond and revise the draft as needed to changes that were made and considered non-substantive. Therefore, no comment period was needed. The final approval was given in April 2019, and it became effective in July 1st of 2019. The implementation process will include a process of a toolkit, and we are still working on that. Next slide, please. These regulations will provide consistency in the EMSC throughout the state. However, they are voluntary, and if a LEMSA chooses to have an EMSC program, they will provide consistency within the state by having these regulations. The regulations will also help us with performance measures 4, 5, 6, and 7, hopefully, with the consistency. Next slide, please. And that is it. And I can provide the regulations to anybody that needs them. They're available on our website. Are there any questions? I went through that pretty quick. I'm sorry.
That was great, Heidi. Thank you. It sounds like it was quite a process.
It was, and Marianne Gaucher-Hill was huge in it, and I'm glad to see she's on this call.
I'm interested what the verbiage issues were, Marianne or Heidi, if you guys want to comment on verbiage on the levels. It seems to be kind of a common.
Verbiage happened before I started. I know that they started with the regulations package being quite large. It had been modified down quite a bit when I got here. I don't know if you want to address that, Marianne, or if you're able to.
Yeah, the issue came, one of the biggest problems, I think, is a hospital didn't want to be called basic. That it was, we had, obviously we had basic, we had general, advanced, and then comprehensive. And really a hospital did not want to be called basic. So we had a whole healthcare corporate system that was really against it because they didn't want to be basic. They thought it should just be 3 levels, just general, advanced, and comprehensive. And so that was a little bit of a challenge, but I think we essentially worked through it with multiple different meetings with different stakeholders, including EMS, agency administrators, as well as medical directors. So we ultimately got through that, but that was a big issue, you guys. It's just the verbiage. And then trying to decide levels, and because some of the issues we wanted to be as inclusive as possible, and I know that creates issues, right? So for the rural areas, we wanted to make sure everybody could potentially participate in the system.
Makes a lot of sense. Any other questions? Okay.
And if anyone does try to call me at this phone number that was on the sheet there, our phones are down because, you know, COVID is ruining everything. So, you know, you can email me at the email there and I can answer any questions as well.
Okay, so our next call is going to be at the end of October. As I mentioned at the beginning, these occur quarterly, 1 o'clock Eastern, 12 Central. If you have any specific topics you want to cover related to medical recognition, we would love to, maybe you can type them in the chat box or you can shout them out. We can make sure that we can find someone that can cover some of these issues and really help everyone succeed. So any more general questions, comments? I don't know if Kate or Mark, anyone you have anything to add?
I just think you guys did an amazing job of sharing these diverse processes and varied programs between the 3 states and the efforts that you've taken to get there, and a huge kudos. And I think just in terms of next steps, it is really important that we hear from you guys and what would be most useful for future communities of practice, if it's how to engage stakeholders or how to develop criteria, or if it's relative to the implementation process, what applications might look like, baseline assessments, things like that. So the more information we get from you about what your needs are, the better we can help to identify you know, folks to help support you and to better guide you. But we need your input in order to know what would be most helpful, because there's lots of steps, and it's a complex process, and obviously requires not just diligence but patience. And I think the work in Illinois and California are clear examples of that. So many thanks to Margot and Evelyn and Heidi for your presentations today.
Great job, everyone. Meredith, I think just a couple of things in the chat box. I've seen some comments about the concept of doing this during the time of COVID and virtual site surveys for prior subsequent discussions. And then some comments about sort of the early phase work. So who's at phase, I forget what the different phases were titled, but pretty early in the process. I do want to highlight that we heard from Indiana that participating in the collaborative is fairly evolved, and that took a lot of time. And then 2 other states that have, you know, sort of decades of work going into this. And within the collaborative, there were people coming from sort of all angles at this, some that have been doing it for a while, some that were starting this for the first time. And I would say that working with Meredith, Kate, myself, and others, we can help to connect you or do some matchmaking with people that are in a similar place that you're at. And there are some resources on the EIC webpage. There's additional resources that are available through our institutional memories of the participating states, but really fantastic work. And I hope that all of us can follow in the very large footsteps and paths that have been paved by Illinois and California.
I think that's a great point, Mark. I think, yeah, we should definitely include, and I see more here from Liz, how to keep the momentum going during COVID-19. So I think that will be a great topic for the fall. Any final questions, comments?
This is Marianne. Just people ask, we are doing in LA, we're doing virtual and paper. We're doing a combination of like send it in and then virtual reviews to not go on site. And I just wanted everybody to know that really the key is just to believe that this is important and be a team player, I guess, would be the corollary. And eventually it happens. Thanks.
Awesome. All right, my email's here on this final slide. So I will send out all the slides to y'all when they are ready. But feel free to email me questions, ideas for future calls, whatever you can. So thank you all.